Well, thank you very much for the opportunity to share our journey with you. It's a little hard probably to tell a 10-year journey in 10 minutes, but we'll do our best. Ours is a story really of practical hospital management, really. To tell you a little bit about us, we do about over 1 million outpatient visits a year across 40 specialties, and a couple of elements that are unique about our organization perhaps that have helped us along the way is we have our physicians are employed and salaried. We also have a centralized scheduling center that certainly helps to drive our change. But fundamentally, what this came down to for us is an issue of supply and demand. So it's from our perspective, it's not terribly complicated, but that doesn't mean it's easy. In fact, it's challenging work. But again, the questions of supply and demand really that requires us we know that there are multiple balls that we are juggling in the air at one time. Any one, if you let it drop, will be detrimental to our advanced access work. So what is it that we monitor and how do we do it? So we monitor how soon can a patient be seen, so with the third next available appointment. So our target in our organization is 10 days or less, and I can get into that if you're interested in how we came to that number as an organization, but that's our internal goal. Do our providers know what their clinical expectations are? This is extremely critical and again, seems very intuitive, right? But it is not necessarily common practice. We have a supply management tool that tracks the clinical effort of each of our providers and matches that to the number of clinics that they're providing. Then the question, so that element of we know what the expectations are those expectations being met? So that supply management tool will tell us whether or not the expectations are being met. And then the question is, are the individual clinic sessions themselves operating efficiently? So we monitor the fill rate of each of the clinics to determine whether or not we've created efficient use of those 4 hours for each individual clinic. And we monitor this, and our goal is to have a target of 95 to 105% fill rate. And then lastly, what are the patients and families telling us about their satisfaction with access as well as satisfaction with wait, which is your balancing measure, really. So this run chart represents our journey. So this measures the percent of our divisions that can provide access to a new visit within 10 days or less. You can see when we started this journey back in 2004, only 11% of our divisions were at that mark. Through learning collaboratives, tests of change, a lot of solid management, we were able to get to this range that sort of our sweet spot in our organization is around that 60 to 70%. The reason why people would say, well, why aren't you going towards 100? Well, the practicality is that there are some divisions for whom the supply and the demand, I think this is the potato example, there are some specialties that simply where the demand so far outstrips supply that we continue to improve but might not get to 10 days. Likewise, we've learned how incredibly fragile this third next available is. There are divisions that you may think that the divisions that are in, it's all the same divisions and that 30 to 40% that aren't meeting it, but it's really not. All it takes is one provider to leave a specialty that's relatively small and their access will creep above our 10-day marker. So that fragility is something that we came to appreciate. So as I mentioned, ours is a story of supply and demand. So we did have strategies that looked at demand, but for the most part, we kept our focus on supply. That's primarily because it was within our sphere of control, right, to do so. So we have several areas that we work on as it relates to supply. So we are analyzing the templates themselves. So there are things that creep into templates that can make things a little less efficient than they could be. So are the appointment durations, are they appropriate, and are they standardized across a division? Do we have any limitations on the number of appointments that can fall into a clinic that might be slowing us down? Slotting in our organization speaks to 8 o'clock, I want this kind of a new visit, 8:30, I want this. All that structured and rule-based model is we found to be very detrimental as well. And so we look at these templates, but the next element of what, and I'll talk a little bit more about this, and Terra will give you a real-life example on it, is this outpatient work guidelines. So what are the expectations of our providers? It took us a few years to sort of realize that we needed this in our organization and needed that level of clarity in order to advance our work. We also used our supply and demand models to identify really how many providers were needed. So there we found that there were some divisions that were probably overstaffed, some that were understaffed, but we used the model. Our ratio in our organization is that where supply is just shy of 120% of demand, we'll maintain that 10-day because it allows for elements of fluctuation that are just that variation that's part of an individual clinic, that's a part of everyday life. And then we explored and have used alternate providers to make our supply pool more robust. So in divisions that have limited access, how can we use advanced practice nurses that may supplement our physicians? So as I mentioned, we have these outpatient clinic work guidelines. They're a critical piece of our organization, and they set the expectations for our providers. So we said every provider has a clinical effort report that says how much of their time is dedicated to outpatient care. We said, if you are 100% outpatient clinical, then that means we expect of you 8 half-day clinics a week. And so then, so everyone else is prorated based on that model. So if you're a 0.5 clinical, then you do 4 clinics a week. And that a clinic is 4 hours in duration. There have been all sorts of definitions in our organization about what makes a clinic. And so we said 4 hours. The expectation is that physicians must do 45 weeks, fulfill that commitment 45 weeks a year, to allow for vacation and conferences as well. If a physician exceeds that 7-week of cancellation, then, and Terra can speak to this, that we have an environment in which you then ask, so when is your makeup clinic? And then coverage policy, our goal is to not deplete supply where the whole division goes out for a conference, because we find rebounding from that takes a very long time. So we try to make sure that we have supply back at the range, so to speak. So I want to introduce Terra, who really will speak to the boots in the ground application.
Good morning. My name is Terra Thompson, and I am a business instructor at Cincinnati Children's Hospital Medical Center. And I have the fun job. I get to implement all this. So we'll start off on this slide, but we did a case study for the Division of Nephrology and Hypertension, and to figure out what the clinic outpatient access was for the division. The steps that we took, the very first steps that we took was to sit down with the scheduling center and review the schedules, the templates, and to see if there was any barriers, any rules, regulations, any restrictions, as David has alluded to. But we found a lot of permission only, that you had to call the division specifically and check with the provider. It was really difficult. So once we went through that data,
Can you speak up a little bit, please?
you bet I can. How about that? Is that better? Okay. Once we determined what those barriers were, we were looking at the data, we were able to identify that we had low supply and our access was really high. Our third next available was at least 30 days plus. At one time it was 60 days. So what we did was division director, myself, we prepared a provider analysis, and we used financial data as well as productivity data. And then we took that data and we aligned their clinical effort with what the organizational's guidelines were. So if they were 100%, then they would have 8 half days and so forth. So once we aligned that and we came up with the analysis, the division director and myself, along with the support of the organizational leadership. Now, mind you, you have to have the right players involved and engaged, because if not, it's not going to be successful. But we sat down and we went through the provider analysis, and this is the first time the providers had seen any type of this information. They have never seen financial, the productivity. It was actually rather eye-opening, I think, for them, and I think they appreciated the transparency. So we explained the needs, the gaps, what we would recommend in the changes, and I'd like to say that it was rather easier than I anticipated, because they are salary-based. They're not incentive-based. So it could have been much more difficult than we, and you're changing the culture in the division. division. I think Dr. Kaplan had mentioned on that, but you're changing the culture. So once we got their buy-in and we were all friends, the next step is, if you can, you can do that. This is a run chart that explains how we implemented it. Immediately, we added 17 new clinics a month. I mean, this was drastic. We had their buy-in. They felt like they were part of the solution. And once we added the clinics, we also implemented the outpatient supply management tool, which tracks the providers' clinic hours, their cancellations, and holds them accountable to what they agreed upon. And as you can see going down, we also, the third next available dropped within a couple quarters. It was very quick. We did implement a no-show initiative that where we added some no-show slots at the end of the day. And this was for patients that were 50% plus no-shows. So we did track that in the system, and we would schedule them in those slots, and that helped maintain the third next available. As Dave had spoken to before, it's a very vulnerable system. All it takes is just one change, and we lost 2 providers, and immediately our supply went down, our access went up. It was very quick too. It took us over a year and a half to recover from this because we had to recruit, we had to get some new providers in there. But we did do that. We were able to get the providers in. We added some more clinics. And as you can see, it dropped as soon as we had the providers in place and added some more supply. It dropped well below the 10-day mark. And actually I moved to a different division, and I'm in gastroenterology right now, and I checked in with nephrology right before I came, and I said, hey, are you still maintaining that third next available? And it's at 6 days. So all the processes that was put in place it's sustainable. So very fortunate, but it does take the right players engaged with the organization, the division level, and providers to make it successful.
Yeah, so this is not for us to review. You have this, but essentially, again, back to the simplicity of it, is that we developed this algorithm that helped support folks in Terra's role with how to think through access. What is it you're looking for? And if you have this problem, we start with initial problems, and we basically walk through this algorithm is kind of our special sauce, so to speak. But again, you have this and can review it and ask us about it in detail. So what lessons did we learn? This requires constant oversight. The moment you take your eye off the ball in any of those facets, it will drop. I can tell you from experience that data integrity and ownership are critical. The data, we spent our first year and a half getting data, having our data told it was wrong over and over and over again. And then we got to a point where, as an organization, we could agree that this is the data we were going to be using and moving forward. We talked about the fragility of the third next available metric. Our clinical leadership, so at the division level, making sure that our leadership at the division level was engaged and understood their expectations was a very important element of it. We used a collaborative environment, a learning collaborative environment that brought divisions together to implement tests of change, and to essentially you had to graduate from the collaborative once you've achieved the third next available. We did that through PDSAs, learned quite a bit, and had that kind of QI support from our Anderson Center in our organization, which is our QI function. And then we do regular reporting. There's a supply management tool. There are reports that are generated all the time so that we are constantly asking these questions. And then fundamentally, from the beginning, we had an organization support at the highest level saying, this is the right thing to do for our organization. So, all right. Thank you. Thanks.